Thank you, everybody, for joining today. Our Common Spirit Health Grand Rounds are hosted by our Chief Physician Executive Office. And a special thank you to our California region for bringing this particular topic forward and sharing it with all of Common Spirit. I am John Morelli. I'm the Assistant Vice President for the Acute Care Clinical Institute, and will be moderating the presentation today. And our topic today is on VTE prophylaxis, diving into difficult scenarios, which we're really going to focus on very specific perioperative states that kind of continue to challenge us from a clinical standpoint as it relates to risk assessment and prophylaxis, and where we as an organization still have some opportunity to reduce our VTE risks. Our learning objectives are shown. Our focus today is really going to focus on evaluating VTE risk factors in medical patients and applying appropriate prophylaxis strategies. Developing a management plan for VTE prophylaxis in post-surgical patients, including considerations for bleeding risks. Analyzing VTE prophylaxis recommendations specific to neurosurgical and orthopedic populations, and applying VTE prevention strategies in trauma patients while considering contraindications and optimal dosing. Now, we've got a great group joining us today from the California region, as I mentioned. It's my pleasure today to introduce our speaker and our panelists today. Our speaker today is Dr. Tom Vendegna. Dr. Vendegna is a pulmonary and critical care specialist in San Luis Obispo, where he's practiced for the past 28 years. Dr. Vendegna also serves as the Chief Medical Officer for French, Marion, and Arroyo Grande hospitals, and is also the current Central Coast Market CMO. Joining us today is just an excellent four-physician panel, including Dr. Christian Chiavetta, who's a board-certified internal medicine physician and the medical director of the hospital medicine program for Dignity Health Medical Foundation at Northridge Hospital Medical Center, and also serves as the current chair of medicine at Northridge Hospital. Joining us also is Dr. Ruby Skinner. Dr. Skinner is double board certified in general surgery and surgical critical care. Completed her surgical training at UC Davis and her trauma surgical critical care fellowship at University of Pennsylvania. Her interests include a focus on developing effective quality clinical platforms in complex acute care settings, so quite appropriate for today's conversation. We also have Dr. William Wang today, who is the Chief Medical Officer at Glendale Memorial Hospital and the Southern California Market Chief Medical Officer for Common Spirit, where he provides integrated clinical and operational leadership across 6 hospitals. And rounding out our team today is Dr. Wyndham Strodbeck. Dr. Strodbeck currently serves as Assistant Vice President for the Anesthesia Service Line for Physician Enterprise. He's in Seattle, where he's practiced at Virginia Mason Medical Center since his internship in 2002, and has been involved in a number of quality and safety initiatives for anticoagulation and regional anesthesia, through implementing automated clinical decision support tools for anesthesia team members, pharmacists, surgeons, and nurses. So thanks all to the panels today, our presenters and our panelists today. And Dr. Vendegna, I will turn it over to you to get us going today.
All right. Thank you so much, Dr. Morelli. I don't know if many of you know this. I'm from Chicago. From the Midwest. We had an up and down week, certainly seeing our Chicago Bears kind of end their run, and then seeing the Indiana Hoosiers go to the national championship undefeated in football. So that's why that little motto is down there. Go ahead to the next slide. So why are we here? I just wanted to bring this back to you. We had a really nice grand rounds in November by Dr. Pandit from Baylor, and she really kind of level-setted VTE and kind of went into some scenarios, especially in medical patients and sepsis. But I wanted to circle back to that, is that VTE is the leading cause of preventable death in hospitalized patients, with a rough incidence of 40 per 100,000 patients. 30% of VTE patients will have long-term side effects, including increased risk of death, morbidity, hospital costs, disability, and recurrent thrombosis. Those patients that have the increased risk of death are usually elderly patients. They have active cancer, surgery, pregnancy, trauma, stroke, immobilization, in the ICU, have central lines, renal failure, prior VTE, obesity, sepsis, CHF, and hormones. So there's a lot of risk factors associated with getting a blood clot and then going on to having a poor prognosis. So what I'm going to do in the next several slides is to look at difficult scenarios, because we know that chemical prophylaxis is the way to go. It really does prevent VTEs, but you'll often ask yourself the question as a practicing physician or APP, why do I want to do this when there's such an increased risk of bleeding, especially in the scenarios I'm going to go through? I'll present the data as best I can, because sometimes there is no data or there's just recommendations. But let's get going. So next slide is kind of, we're going to start with GI bleed and go on, John. Next slide. So let's talk about GI bleeds in general for a second, because this comes into play of when you're going to do your VTE prophylaxis. Two types of GI bleeds, as everyone probably knows: upper GI bleeding, lower GI bleeding. Most common upper GI bleed is peptic ulcers, then gastric/esophagitis, and then esophageal varices in that order. Lower GI bleeding, the most common is diverticular, then hemorrhoidal, then ischemia. The risk of rebleeding kind of really goes on whether you can do an endoscopy, especially at upper GI bleeding, because if you see a ulcer that is spurting blood, that risk of rebleeding is 80 to 90%, so a very high risk. However, if the ulcer is clean based, it's really low, less than 5%. Of course, there's a lot of gray zone in between. The rate of rebleeding in a lower GI bleed is 10 to 20%, so not that high. Variceal bleeding without treatment, which is very rare these days, is 30 to 50% chance of rebleeding, whereas when we treat them with ligation and then put them on meds, it's less than 20%. And then at the bottom, I like the AIMS 65 mortality predictor. I learned it a long time ago studying for boards, and it still applies. A patient who presents with a low albumin and a high INR, altered mental status, a blood pressure less than 90, and an age greater than 65 is certainly at increased risk of death with a GI bleed. So keep that in mind as we talk forward on this. So go to the next slide. So what do you do when you have a GI bleeder? You gotta hold your pharmacological prophylaxis immediately if they were on it, or don't start it. Definitely consider mechanical prophylaxis immediately if it's not in place already, and then investigate the source of bleeding and treat it. So as I referred to in the last slide, you really want to know where the bleeding is coming from and what it looks like, because that'll kind of determine what you do next. And then I like to use a risk calculator. And Dr. Pandit really kind of talked about all three calculators. There's the Caprini, there's the Improved, there's the Padua. I like the Caprini. It's very complete. The next slide will show that. So go ahead, John. So the Caprini risk factors, they're pretty robust. It kind of goes through a point factor system, but I want you to focus your attention to the bottom. It goes over a very low, moderate, and high risk. And you can see over the far right on the bottom, kind of the chance of having a VTE if you're in one of those categories. And if you start to get into that high risk category, it's certainly a high chance that you could have a VTE. So that goes into play of what you do next. So next slide. This is kind of the breakdown. Has the bleeding stopped? If yes, what did it look like, first of all? Are we talking about an EGD showing a vessel that's bleeding blood, or are we talking about a clean-based ulcer? Because if we have a Caprini risk of greater than 5, meaning a very high risk, we know that we have a 6+% chance of VTE. And if it's a clean-based ulcer, we know that it could be, very minimal chance of rebleeding. So those patients should be started on prophylaxis within 24 to 48 hours. The problem comes when you have a high risk of rebleed and a high risk of clot. So that's where the difficult situation comes into play. And I'm sorry, these are recommendations. We don't have good prospective trials for GI bleeding. Of course, you want to continue your mechanical prophylaxis. And if the bleeding hasn't stopped, continue your mechanical prophylaxis. And if they have a high risk or active cancer, you can consider an IBC filter, but that's really kind of very controversial because bleeding usually gets controlled. So that's something to keep in the back burner, but we rarely do it these days. My days in pulmonary critical care, we used to do it a lot more frequently, maybe 15, 20 years ago, but not so much now. So next slide, we're going to start to go into the pre-op and post-op surgery, and then into really difficult surgical scenarios. So in general, next slide, we'll talk about surgery. There's two risks for surgery. First of all, the procedure, which is the duration, the intraoperative positioning. We have anesthesia. They can make a comment about that in the panel later. The type of anesthesia, and then post-op mobility. The highest risks are the major surgeries, of course, a prolonged surgery, an emergent surgery, post-op immobility that lasts for greater than 3 days or prospectively going to be greater than 3 days down, and then critical ill surgery such as a burn patient, a trauma patient, or a brain and spine surgery patient. And then you have, of course, the patient-related factors, and this goes back to the Caprini risk calculator. Again, the age, cancer, stroke, CHF, renal failure, prior VTE, actually rheumatologic disorders play here, obesity, and hormone therapy. Okay, next slide. So so the bleeding risk with chemical prophylaxis, this is the key crux question here. What is really the risk in general overall in surgical patients? Now I'm talking overall in surgical patients. I'm going to get into some difficult scenarios. But what is the risk if I put someone on chemical prophylaxis? What is their chance of bleeding? And really it's pretty low. It's 2 to 4%. So it's pretty low, and that's not usually typically major bleeding. The highest chance is in cardiac surgery, that's at 5%. I told you on the Caprini risk that the highest risk is over 6% of clotting. So you have to kind of weigh that risk benefit because the bleeding risk is going to be in the 2 to 4% chance. Active bleeding obviously is a contraindication. Severe coagulopathy is a contraindication, including advanced liver disease and bleeding disorders where the platelet count is really low. Remember, like especially the active bleeding and bleeding disorders, we can control those. So we really have to assess this on a daily basis because that high risk may go away or get remarkably reduced. And then a little side note, epistaxis and menstrual bleeding, unless it's severe, is not a contraindication to chemical prophylaxis. Go ahead to the next slide. So the timing of prophylaxis, mechanical prophylaxis obviously can come on even before surgery, but certainly immediately after surgery. And then in general, chemical prophylaxis can start within 2 to 12 hours postoperatively. Now, I'm going to give you scenarios where that's not the case, but this is in general. And if you're using fondaparin, which I have never used in my career, but it's in 6 to 8 hours postoperatively. The duration for surgery patients, it's when they're fully ambulatory and usually upon discharge. We usually continue it all the way to discharge. The exception is a cancer patient. There's some data that says you should probably go extend that to 10 to 14 days. And certainly if they have abdominal pelvic surgery for cancer, Lovenox is the recommendation for up to 4 weeks postoperatively. Next slide. So here's kind of 4 scenarios for you. In a very low risk Caprini patient where you calculated it and their VTE risk is about 0.5%, you want to get them up. These are young patients who have a minor procedure. If you have a low risk where you're now calculating a VTE risk around 1.5%, these are usually lap choles, lap appies. You want to use mechanical prophylaxis. If you have a moderate risk, now we're starting to get into the gray zone because remember I told you the risk of bleeding on chemical prophylaxis is 2 to 4%. And in this category, the risk of a VTE is 3%. So we're right on even par here. The general recommendation, if there is a low risk of bleeding, is to use chemical prophylaxis. This is an abdominal, pelvic surgery, cardiac surgery, thoracic surgery. So this is your basic, pretty much bread and butter surgery here. And then if you have a high risk patient who has a Caprini of 5 or greater, they have a 6+% chance of VTE. They should be on chemical prophylaxis unless there is a lot of bleeding going on. This is extensive thoracic, abdominal, or pelvic surgery. So that's kind of the general rule for surgery. Next slide. So let's starting to get into now these difficult scenarios. And here's where we really want to kind of dive into some of the data if available. Next slide. I'm going to talk about three scenarios here. First one on the left, traumatic brain injury. In the middle, brain tumors. And in the right, spine surgery. Next slide. So the data. Oh, first, Caprini risk factor. I wanted to mention this. If you do a Caprini calculator on a lot of neurosurgical patients, they're going to get into that high or certainly moderate category because they're usually over 60. They've had a major surgery that's open, and a lot of times they're confined to bed for up to 72 hours. So you can see right away you're going to deal with a high-risk patient. So I just want to put that out there as something to remind you all of. So next slide. Let's talk about traumatic brain injury. And I have data for you here. So we have two papers here, one out of JAMA in 2022. This is from Johns Hopkins. It's a robust study, but it is a retrospective cohort study where they looked at approximately 5,000 patients and showed that chemical prophylaxis definitely improved the VTE risk, but patients went back to the OR if it was done within 3 days. So over 3 days is the kind of the key here, which is backed up a little bit more by Surgery 2024 article that they, the Wisconsin group, Morris's group in Wisconsin did 351 patients in a single center retrospective trial. And they definitely showed that chemical prophylaxis was safe after 72 hours, and it decreased the VTE risk from 13% all the way down to 5%. So there's some hard data for you, and it's fairly recent. Next slide. Let's look at brain tumors. So this is an article in 2019 on the left, Seminars in Thrombosis and Hemostasis. This was a review article by Riddell, and it's a large article, but it does say that in especially glioblastomas, the risk for VTE can be as high as 30% postoperatively. So these are very hypercoagulable patients. So keep that in mind. And then in neurology study in 2025, this was done by Glart. It's a meta-analysis of 762 publications. So again, very robust. And it says that chemical prophylaxis appears safe in both primary and metastatic tumors. And the other thing that was interesting is there's a bend towards using direct oral anticoagulants such as apixaban or rivaroxaban over low molecular weight heparin, which actually showed a slight benefit. So keep that in mind, but definitely chemical prophylaxis helpful in tumors of the brain. Next slide. So the final scenario is the spine surgery. This is North American Spine Society, a systematic review and meta-analysis. It's large. It's by Ramani, sorry. And basically what they said is that the VT incidence is less than 4%. So now you're getting into that very gray zone because the bleeding on these patients is between 2 and 4%. Granted, it's minor bleeding, but the risk of VTE is also low. And most of these patients nowadays, especially in 2026, are ambulatory post-surgery very quickly. So the chemical prophylaxis was inconclusive in this study, and the recommendation was more ambulation. So this next slide kind of puts it all together for neurosurgery. The general recommendations: mechanical prophylaxis for all. For traumatic brain injury, 72 hours is the key. If the bleeding has been controlled and stopped, very highly consider chemical prophylaxis. In brain tumors, if there's bleeding control within 24 hours, that's when it's recommended to start. And in spine surgery, it's recommended to get them up and about. And then again, back to my days, IVC filters was highly considered in brain surgery. It is now not recommended unless the patient is coming into the surgery with a known DVT. So really, it's more contraindicated. And definitely, if you're going to use an IVC filter, you remove it as fast as you can. That's a removable filter within 3 months. Next slide. We're going to go into orthopedic surgery. This is a tough one because we have two societies that are going to weigh in heavily here. So next slide. So when I'm talking about orthopedic surgery, the Caprini risk calculator was designed without orthopedic surgeries in mind. So remember that the Caprini risk calculator is helpful, but it wasn't done with these patients. I'm also not talking about patients who have a fracture of their hand or elbow, where they can get up and walk about really quickly, especially young patients. I'm also not talking about pelvic ring fractures because that's trauma, or multiple lower extremity fractures. So I'm talking about orthopedic surgeries in major extremities. The chance of VTE is up to 30%. The average is closer to 5%. So on general, the chemical prophylaxis is recommended because remember the risk of bleeding is 2 to 4%. Again, you got to be careful or contraindicated in someone who's actively bleeding, low platelet counts, or a coagulopathy. So let's go to the next slide, and you're going to look at two societies battling each other slightly. This is the American College of Chest Physicians, which I belong to. This is the pulmonary and critical care docs. What we look at is data. We want to know if there's blood clots present. We don't necessarily know about the bleeding because we're not surgeons. And then you have the American Academy of Orthopedic Surgeons who want to know if there's a clinical clot present. So their data is based on clinical clot present, and they're very concerned about bleeding. So you can see there's two different approaches. And I put up total hip and knee as well as hip fractures, but major shoulder surgery kind of goes in line with hip and knees. So just for your awareness. So the ACCP, they like low molecular weight heparin or a direct oral anticoagulant. The AAOS likes aspirin or a direct oral anticoagulant. The timing, the ACCP says within 12 hours. So after 12 hours, start the DOAC or the low molecular weight heparin. The dose for the DOAC is a little lower. You can see there rivaroxaban is at 10 milligrams a day and apixaban is 2.5 milligrams twice daily. The duration for the ACCP is 10 to 14 days for a hip surgery and up to 35 days. You can substitute aspirin if the patient is doing well at 5 to 10 days. The AAOS is simple. It's aspirin 81 milligrams twice daily for 35 days or a DOAC for the first 10 to 14 days and then go with aspirin. And you can see why a lot of surgeons like the AAOS recommendations. Is one better than the other? Well, that's very controversial because the ACCP, again, looks at all clots, whether they're clinical or not, and they would recommend that, yes, their recommendations are better. But clinically, maybe not the case. And then total knees, those patients don't clot as much. So the recommendations are slightly different. The timing is the same. The medications are the same, but the duration for ACCP is 10 to 14 days. If they're fully ambulatory, then aspirin can be substituted at 5 to 10 days. If they're not ambulatory, then you have to kind of go back to what they do for hips to 35 days. AAOS, again, 81 milligrams BID or a DOAC for at least 10 days. Hip fractures, both societies know that, especially in elderly patients, that the risk is pretty high here. Again, the ACCP is going with low molecular weight heparin or a DOAC, where AAOS is aspirin, and at minimum 10 to 14 days, but most societies say up to 35 days because these patients are at higher risk. So again, I threw a lot of data at you, two societies kind of going at it from two different angles. But I would look at your programs and see if, one of these kind of scenarios is taking place. Next slide. And what about mechanical prophylaxis? Alone, not recommended unless there's chemical prophylaxis is contraindicated. We don't know in orthopedic patients whether chemical and mechanical prophylaxis adds benefit. We know it's no added harm, but we don't know if there's added benefit. Plus, one of usually the limbs is involved here. Next slide. So what about trauma patients? Well, Trauma Society is really good at looking at this data, and we have a trauma surgeon on our panel. So think about that as you're looking at my data. Next slide. So trauma patients have a moderate to high risk. I mean, the incidence straight off the bat in all trauma is about 12% chance of VTE untreated, 7% if you use mechanical prophylaxis, and less than 5% if you use both. The incidence varies, and it's based on comorbidity and age, and I have some scenarios there. The Caprini risk calculator was not used in trauma patients either. So you have to kind of weigh that in, that these patients have a very high risk, especially if they have spinal cord injury, head trauma, lower extremity or pelvic fractures, prolonged immobilization or hospital stay, an age greater than 40, or they're obese. So Next slide kind of goes through the scenario. So mechanical prophylaxis, we know that reduces the risk down to 7% by itself. If we add chemical prophylaxis, we are under 5%. Higher minor bleeding with chemical prophylaxis, but not major bleeding. The Trauma Society recommends low molecular weight heparin over unfractionated heparin unless there's renal insufficiency or failure, with similar bleeding seen in both. Combined prophylaxis of mechanical and pharmacological is added benefit. It's one of the few areas where there's added benefit. Prophylactic IVC filters are not recommended unless the patient is going to have significant reoperations and bleeding. So that's something to consider. We used to, again, in my day, put IVC filters in a lot of these patients. Now we hardly ever do it. Next slide. So what are the contraindications? Of course, active bleeding. But then you have some kind of specific scenarios. Again, intracranial hemorrhage, we talked about this in the TBI section, 72 hours if after stabilization. Then you can begin low molecular weight heparin. Spinal epidural hematoma, 72 hours after stabilization, and then begin low molecular weight heparin. If there's a significant ocular injury, we need a consult from ophthalmology and clearance before we begin low molecular weight heparin. In an unstable spinal cord fracture, again, 72 hours after stabilization. If chemical prophylaxis cannot be placed, mechanical prophylaxis should be in place already. And then the big thing is to reevaluate every 24 hours because these things change. And then the dose, at minimum, the Trauma Society recommends low molecular weight heparin at 30 milligrams BID. Unless there's renal failure, then unfractionated heparin 5,000 units every 8 hours. That's minimum. A lot of centers now are going to 40 milligrams BID, so being more aggressive. Next slide. Prolonged VTE prophylaxis is probably recommended in patients with significant orthopedic injuries, even after discharge, up to 6 weeks after discharge, with at least aspirin 80 milligrams BID or 325 milligrams daily, with the exception if they're already on Plavix, Coumadin, or a DOAC. Patients with paraplegia, and I used to see this in my career quite frequently early in my career, we used to see a lot of patients become very hypercoagulable within the first 3 months and get blood clots. Now the recommendation is to put patients on low molecular weight heparin up to 30 milligrams or 30 milligrams BID for 3 months to kind of prevent this hypercoagulable state that you'll see after spinal paraplegia. And interestingly, the patients actually lose that hypercoagulability after 3 months. So that goes way down. Next slide. So what about urologic procedures? Next slide. So this was really well summarized in the Urology Journal in June of 2024, because what they did is they took recommendations from the Canadian Urologic Association, the American Urologic Association, and the European Urologic Association, and kind of combined them, used the Caprini risk calculator, and made recommendations. So I really like this review, and it's down to 5 scenarios, and here they are. Next slide. So a radical cystectomy. Post-operative VTE rate is anywhere between 4 and 24%. If you use a robot, it reduces it to 2 to 5%. If the patient has had neoadjuvant chemotherapy or a previous VTE, COPD, prolonged hospital stay, or lymphadenectomy, that increases the risk. So if you have a patient with a high Caprini score, high risk, low molecular weight heparin or sub-Q heparin or a DOAC is recommended for up to 28 days. So high-risk patients, especially if they're open and not with a robot, you want to anticoagulate them for a while. A radical prostatectomy, the open rate is 1 to 16% chance of VTE post-op, whereas with a robot, it's really low, less than 1%. So again, a high-risk patient with an open procedure should be on low molecular weight heparin or sub-Q heparin for a prolonged period of up to 28 days. If you're using a robot, then mechanical prophylaxis should be considered routinely, and only use the in high-risk patients, consider chemical prophylaxis. But we don't know the duration on these patients because, again, the rate is pretty low with a robot. So keep that in mind. In a nephrectomy for cancer, the VTE rate is 2%. Radical definitely has a higher risk compared to partial. So pharmacological and mechanical prophylaxis is recommended for a radical, but we don't know the duration. Where partial is interesting because if you're doing a partial nephrectomy, the chance of bleeding actually goes up with chemical prophylaxis, so it's very controversial in a partial nephrectomy. Next slide. So what about an open simple prostatectomy or a transurethral resection of the prostate? If the Caprini score is low, the risk is about 2.5%. If it's a high-risk Caprini patient, it's around 11%. And with a TURP, it's down to less than 1%. So in a high-risk open procedure, chemical prophylaxis is definitely recommended, and then consider mechanical in addition. If you have a TURP, those patients are going to get up and walk them almost immediately. So really the recommendation is ambulate them. And then finally, if you've had a nephrectomy for a non-cancer, then the open approach, the rate of VTE is around 5%. So those are patients I would consider with a high risk, especially on Caprini chemical prophylaxis. Otherwise, it's kind of controversial. And then the next slide, I gave you a table, which you'll get the slides. These are difficult to see, but it kind of goes to the nuances of urology. It's from this article. It's really good. It kind of can see where there's benefit and help, and data. So that I added that in. So the final slide is my summary. And this is my dog Tazzy. Golden retrievers, they like to kind of focus and they kind of have one thing on mind. So I'm going to be repeating several things, and this is what what Tazzy would be doing. VTE is preventable, especially in medical and surgery patients. I would definitely choose a risk calculator for VTE. I like the Caprini. The Padua is a little simpler. The Improve is a little simpler. Chemical is definitely better than mechanical, but that's better than nothing. Prophylaxis should be started as soon as possible. And then this is the key. Reassess daily. Contraindications to chemical prophylaxis are active bleeding, severe coagulopathy, or a low platelet count, but those change on a daily basis. So back to reassess daily. The biggest opportunity for improvement is post-surgery patients or post-bleeding procedure patients. Try to follow the guidelines and restart chemical prophylaxis as soon as you can. And then again, one more time, reevaluate daily. And I thank you very much.
Great, Dr. Vendegna, thank you so much. Really covered probably, I think, one of the most important topics and the topics that really garner the most questions and concerns about, when do you start? Is it safe to start? So thank you for that. We've got only one question in the Q&A, but I do have a couple questions. But before we move on to the questions, just want to sort of ask the panel, any comments on Dr. Vendegna's presentation, any particular topics or areas that you think that you might want to expand on? And I saw Dr. Wang lift up his hand first. So Dr. Wang.
Thank you, Tom. I think that was a great presentation. I think for our viewers that are listening to this, what we do know is that we have to keep this top of mind as the first thing, and I think Tom talked about that. And I think the other part is that Tom had talked about excellently in his review, is that we have to evaluate this on a daily basis, right? And so please allow our system knows this. We have data that shows that this is where our fallouts are, and we've designed a system in place to help mitigate that, to help first remind you, bring this top of mind, hey, did you use some kind of tool to help you assess the risk? And then we've got other systems in place to help remind you on a single day, hey, is it okay to start now? Is it okay to start now? So we're trying to help the patients and you keep this top of mind, because this, like Tom said, this is preventable. And what we always forget is this is not, VTE has a long-term sequela, for our patients, right? It's not just, okay, we'll just give them some anticoagulation and that's it. They've got pain postoperatively. They've got swelling chronically, and then they could possibly, have pulmonary embolisms after that. So we allow us to help you keep this top of mind and help prevent this from happening.
Yeah, thanks for that comment, Dr. Mike, because I think you're absolutely right. I think our opportunity really is on these post-surgical patients, or any critically ill patient, to reassess those risks and start that prophylaxis as soon as we can when it's safe to do so. So thank you for that. Dr. Skinner.
Tom, I want to thank you. I think this was an incredible talk. And, we've talked about this, the fact that you can summarize really big topics that are grand round topics, so concisely is amazing. For the trauma population, and really the literature and the evolution is 24 hours, within 24 hours of injury, to start anticoagulation, even in traumatic brain injury. There was a recent study that came out through AAST, a large observational prospective study from 17 level 1 trauma centers that demonstrated that patients have lower risk for VTE when starting early, and rebleeding is very low in both early and late groups. And just to put this into perspective, the trauma evaluation of coagulopathy after severe injury has the research, really dates back a couple of decades. And what is known that in acute injury, there is an initial coagulopathic state, but within 12 to 24 hours, the patients then transition to a hypercoagulable state. And, that's associated with surgical control of bleeding, resuscitation, and reversal of coagulopathy. And it's similar to what we know about sepsis. The hyperinflammation that you see early on then switches to a hypoinflammatory response. And so the clinical practice really matches what is known about what happens in trauma patients becoming hypercoagulable within 12 to 24 hours. So it is safe. But again, you mentioned all of the scenarios: acute bleeding, coagulopathy, and things like that. Those patients are at risk. But across the board in these difficult scenarios, we need to reassess and start anticoagulation as soon as possible.
Thank you, Dr. Skinner. You got your hand up, Dr. Chiavetti. When I gave this talk at Northridge, I mean, the trauma surgeon, got up immediately and said, we really push the anticoagulation. So yeah, I thought of you right away when I saw your hand go up. Go ahead.
Yes, our trauma surgeons are actually the people that really stewarded this push inside of our hospital. Dr. Saad is who you're speaking of. So he's been a real steward behind that. I was fortunate enough to be at that lecture, Tom, and I was really grateful for these slides because as a hospitalist, and I can speak for my team here in Northridge, one of the biggest things we struggled with was each and every scenario that you basically described when we're trying to make multidisciplinary decisions on these really complex patients. So these slides are great. And it really gives us some confidence from the hospital medicine perspective to make decisions with confidence, knowing that there's good evidence-based medicine behind this. My question for you, I guess, is around the orthopedic injuries of the shoulder. So can you speak a little bit about that, or do you have any information behind the shoulder injuries and DVT prophylaxis?
Yeah, and I think we were kind of mentioning this. The data kind of follows the hip, and I kind of mentioned that in the slides too. The data follows the hips and knees. The problem with the hip and knee data, as you saw, is you got two different societies going at each other, slightly. I mean, you have my society, the ACCP, who just looks, if there's a clot present and trying to get rid of clots. And then you have the surgeons who say, hey, I'm worried about the bleeding too in that little joint space. And I'm worried about clinical clots. So it is a little bit, you want to have something. So I think aspirin or a DOAC, is definitely should be there at least at minimum for a shoulder, and then consider low molecular weight heparin as well. So that's would be the recommendations. Yep. I have a
Great.
question for Dr. Strodback, actually. You know, when I was reviewing all this, the positioning and anesthesia, I never even thought about it until I started really reading the topic, and I was like, well, yeah, that makes sense. Do you guys like really think about that with positioning and kind of, you know, your anesthesia and the durations and stuff like that?
We certainly thank you so much for that question and for this fantastic presentation. Uh, I would say that positioning is certainly a concern, although almost no anesthesiologist has ever convinced a surgeon to place a patient in a position where the surgeon didn't want them. So from the point of view, though, of anesthesia considerations, I'd say there are a couple. One is the type of anesthesia, and we certainly have a pretty interesting background of evidence around type of anesthesia influencing risk of DVT. And in patients that are candidates for spinal anesthesia or neuraxial anesthesia, there is a significant blockade of the sympathetic nervous system and thus less activation of the hypercoagulable state. This has been measured from hematologic work that was done even 40 years ago, looking at patients undergoing hysterectomy under epidural versus general anesthesia. So this is pretty well understood, and large studies that have been published even within the last couple of years in arthroplasty, looking at a large VA population of patients undergoing total joint arthroplasty showed a significant reduction in those that had spinal anesthesia. The second consideration is the type of analgesia provided afterwards. And this has been an ongoing discussion around the use of epidural analgesia for the purposes of helping to promote good pain recovery. But there's also a strong association between epidural analgesia and reduction in VTE, at least in patients that are, for other reasons, perhaps poor candidates for strong chemoprophylaxis. This is, there was a publication in JAMA Surgery coming out of Cedars-Sinai looking at about 120 patients who underwent oncologic surgery and had epidural analgesia in place and had a very low rate of VTE despite not being treated at all with any chemoprophylaxis. So there is definitely a component of collaboration that needs to take place. However, that being said, there are other considerations, including having a neuraxial catheter may in fact create some complication with collaboration around the type of anticoagulation or chemoprophylaxis that's utilized. And that requires close collaboration between the surgical and anesthesia teams managing the postoperative pain. So definitely a close tie-in, and I appreciate the question.
Great question. Thanks, Dr. Strodback, for jumping in. We do have a few questions on the Q&A, so I'm going to walk through those, and I'm going to ask the questions and not direct them to any particular panelist, so feel free to jump in. The first question was about, can you share the research articles that use the less than 50,000 platelet levels? So I'm presuming this is, Tom, the comment that you made about 50,000, lower than 50,000 platelets sort of increases bleeding risk.
Yeah, I mean, I think that's general recommendations in every society that you see. You know, there is really not good data to kind of back that up. But I mean, every a VTE article you'll read, you'll see that low platelet count under 50,000. You know, so yeah, I don't have any specific research article that backs that up, but every society kind of goes with that. Kind of general recommendation, unless I don't know, Ruby, is there anything in trauma that kind of specifically addresses?
I think a lot of this is based on observational data, observational studies. Even the trauma literature supporting early anticoagulation, are based on large database studies and observational patterns. So there's certainly studies out there that look at, the platelet count and the incidence of bleeding. It's embedded in the trauma literature and, also other areas.
And remember, we can, potentially fix the platelet count. We can make it go higher.
Right.
So, yeah.
Right.
Yeah.
I think one of the last articles I saw was on the management of or the prevention of DVTs in our sepsis patient population. Dr. Skinner, you made the comment before that these are very hypercoagulable patients. And the 50,000 platelet was the cutoff. Although we see now there's more in the literature that some of these institutions are now going down to 30,000 platelets
Mhm.
and feeling that it's safe enough down to that level. So I think that the 50,000 is pretty well supported. Question on different types of mechanical prophylaxis. Question is, I think sequential compression devices are most effective versus TED hose. Any benefits to using both together?
I have not seen that data at all. Definitely the sequential definitely rides supreme in this for sure. But I have not seen the combination data. Just like what I said with the combination data with mechanical and actually chemical, the only really literature that supports that is the trauma literature. Everywhere else it's controversial. So I think that if you're going to use mechanical prophylaxis, the sequential compression devices are the best. But there's no real data that supports using multiple together. Yeah.
All right, there's a question on end-stage liver disease. So end-stage liver patients are known to have an elevated DVT risk, but they also have a high bleeding risk and are going to have a high INR and low platelet counts. What are your recommendations in this patient population?
This is something that the surgeons can really comment about because if you have someone who has a really advanced liver disease, they're gonna have a chance of having a clot in their hepatic system because they can be both hyper or hypocoagulable. So they're difficult. Especially if you're operating on their abdomen or near their abdomen. So I don't know, Dr. Wang or Dr. Skinner, you may want to comment about that, but those patients are rough because certainly they can clot in the system where you don't think they're going to clot. Ruby, you want to unmute.
Oh, can you hear
There you
me?
go.
Okay.
Yep.
Do you want to go first, Dr. Wang? I was gonna let you take this first.
Yeah, having done a number of these and having a clean tap and then having it turn bloody, I have to agree. We're very hesitant on that, especially when it turns into frank blood, and then you have to go in laparoscopically and find out what was it. There's a piece of momentum that was in the place and won't stop bleeding. It has been problematic. I have started it again after around 12 hours of clean tap and not having an issue, but certainly before that, I did have an issue. We have done one in the operating room, and our anesthesiologist at that time, we were using Toradol a lot for postoperative pain, and it was everybody was like that at that time was a great thing. That patient happened to have Toradol, and about an hour later, the tap had turned bloody. And so I blame the anesthesiologist for that.
Right. It's always anesthesia. No, I think the liver patient is a good example of patients can be hypercoagulable and coagulopathic at the same time. When trauma patients come in acutely bleeding and they're coagulopathic, they're also clotting. And so it's a dynamic process. And, again, if your hospital has tools such as TEG, ROTAM, and things like that, you can really use those two tools to guide how you manage, acute patients, particularly acutely bleeding patients, to give some guidance. But those high-risk coagulopathic patients also need to, be anticoagulated, during times of stability to avoid, the PEs and things like that.
I'm glad you mentioned the viscoelastic testing because Dr. Morelli and I are on a different kind of segue, kind of really looking into that. And it's so helpful especially in the trauma patient, but probably can be helpful in the liver patient. There's
Yes.
data for that as well.
Yes.
Yeah.
Yes.
Yeah.
All right, the question about cardiac surgery, and I think Dr. Vendegna, I think you touched on this on one of your slides. The question is, we often see aspirin 81 milligrams daily or BID. However, based on the Caprini score, most of these patients fall into a high risk category where usually low molecular weight heparin is recommended. So any thoughts on the benefits of aspirin versus low molecular weight heparin?
That has not been studied head to head. Having said that, I, in my career, have seen over time I think because we're doing harder patients post-operatively for heart surgery. They're older, they're sicker. I've seen more clots post-operatively in the last 5 to 10 years. Christian, I don't know if that's the case with you, taking care of patients too. So we are tending to now put patients on chemical prophylaxis with low molecular weight heparin, especially if they're going to be down for a little bit and they look like they're not going to move very well.
Yeah,
Any
that's correct.
yeah.
Yeah, our CT surgery team here is very aggressive with starting DVT prophylaxis as soon as possible. And I think that leans into the sick population that we take care of nowadays, that they're not just straightforward cabbages anymore. They have several other comorbidities, and often come in as emergency cabbages too. So yeah, we definitely prophylax them very quickly here at Northridge.
Yeah, I'm glad to hear that because, like you just said, the Caprini risk calculator on most of these patients these days is pretty high. Yeah.
And there is some orthopedic data, and you and I have talked about this, Tom, that have compared aspirin to Lovenox or heparin, and have demonstrated that aspirin is non-inferior. So I think there is some evidence to support one or the other, but they're very different mechanisms,
Yeah.
again, and I think using other tools to guide the management of the patients, if there's access to TEG and things like that, can be very helpful.
And John, I'll mention the taboo topic here, is the upper extremity lines. Because a lot of these patients have lines, they're accessed and we talked about this, we talk about this all the time. I had a problem with this in my own institution. Lines clot, especially upper extremity lines. So that's the other thing you got to think about especially in heart patients, is get the lines out quick, because they're gonna clot. Even if you put patients on prophylaxis.
Yeah, that's a good point. It is a difficult topic, and when we look at our opportunities across Common Spirit, it's the upper extremity DVTs that we have the greatest risk right now. So you're right. I think it's it's appropriate line selection and making sure that you're using the lines when you need them, and then using the most appropriate line. But like you said, I think it's line hygiene when they're in, maintenance of the line, but discontinuing the line as soon as it's clinically safe. That really is our only opportunity. Questions on medical patients. Patients who are diagnosed with a stroke and are placed on dual antiplatelet therapy, for example, do they still need DVT prophylaxis?
Oh, that's a tough question. Christian, you may want to pipe in here. I don't know if the data would support that. Certainly, if you're going to be on an antiplatelet and an aspirin, I don't know if I'd go there unless the Caprini risk calculator is extremely high, active cancer, unknown DVT in the past. I probably would stick with the dual platelet approach, but it's controversial. You may want to comment about that.
Yeah, it's that's a very tough scenario. I think you have to lean into the comorbidities that are associated with the stroke, like you alluded to. Was it a cancer-related stroke? I think also it depends on mobility and the Caprini score as well. So I think you just have to weigh the risks and benefits with that. It really depends on how the patient did after the stroke, right? As well, too. Are they mobile? Are they now bedbound because of the stroke and on aspirin and Plavix? So I think that's like that gray area that you're kind of alluding to, that we kind of just got to take it on a case by case basis. We do have patients here that are on, both. We have an acute rehab unit here where they do not start off very mobile, and we kind of just like you've alluded to, reevaluating this on a daily basis. And I think that's something in the hospital medicine umbrella that we probably could do a better job of sometimes. And I think that alludes to a question that I just saw in the Q&A too. But yeah, I think it's a case by case basis, just doing that daily risk assessment.
We have an interesting question on the chat. It says, does elevation have a role in any of this? This particular physician moved to a new practice at a higher elevation with an older patient population and now has double the DVT and PE rate that he had previously. Question is, should I be upping my anticoagulation even more on these patients?
Ooh, that's a good question. I don't know,
Okay.
Ruby. I don't. Yeah, you may want to comment
Yeah.
about that. I think at higher
It,
elevation, you're
you,
dehydrated, so your flow is.
your hemoglobin concentration is higher due to DPG levels and things
Yeah.
like that. So probably there's I don't know if the exact science is known, but certainly there's likely a higher risk for clotting. Um, so that's a really interesting scenario. And there may be some inherent differences to demographics there, but certainly those who are chronically who live in elevated areas chronically have different hematologic profiles, if you will.
Yeah, that's a great question. I trained in Colorado, and we'd see hemoglobins, and hematocrits like above 50 in patients that
Yes,
came from like Leadville, which was 10,000 plus feet. You would think that they were a little bit more higher chance for clotting.
right.
And as a cyclist, John, we know that if you inject EPO and get that hemoglobin way up, they clot, they get a stroke. That we know. Yeah. Yeah.
Good point. So, Vendegna, you talked about the risk of bleeding in these patients based on the clinical scenario. The question here is: is there a difference in risk of bleeding using Lovenox versus heparin?
I think the studies and most of the things that I've read, it's non-inferior, meaning they're about the same. I don't see one superior than the other as far as bleeding risk. I think low molecular weight heparin is slightly superior when it comes to VTE prophylaxis, but bleeding risk non-inferior. So yeah, I don't see an added benefit of one over the other as far as bleeding, but definitely as far as preventing clot, low molecular weight heparin.
Yeah, there's a question about upper extremity lines again. Dr. Vendegna says, upper extremity lines, any opportunity to use a smaller lumen, would that be helpful? I think we've talked about this many times during a number of conversations that we've had, even some of our System VT calls, that the answer is yes. The smaller the lumen, the less number of lumens, the lower the risk. But again, that is one step. I think probably the more appropriate step is the appropriate utilization of discontinuation rapidly. But
Right.
yes, smaller lumens clot less than larger lumens do.
Yeah, well said, John. Yeah. Yeah.
Right. And definitely midlines, there's a clotting risk. PIC lines,
Mhm.
patients going home with PIC lines for long-term antibiotics, they come back in the hospital. Those patients likely should be screened, for upper extremity DVTs, for long-term lines. If you look for them, you will find them.
The other,
True.
make a comment real quick, in the ICU, what we were doing, and really reduced our risk of clotting with lines is a lot of times the patient was getting like a central line from the ED, and then they would switch it over to a PIC line within the next 2 days, which it really increased our risk for clots because then they would keep the PIC line for 7 to 10 days. And then, of course, we'd get a clot. So yeah, use your central line early, but then get it out and go with something that is more peripheral or a midline, anything, but not a PIC line. Yeah.
Right.
Yeah.
I just
Right.
wanted
We've
to say
got,
one quick thing before we go, because
go
I
ahead,
looked at the
Dr.
question. So this all starts with a physician and doing the risk assessment. Let our system help you because everything falls underneath that. If we have the risk assessment that you've done, there are systems in place that can come up behind you and help remind you about, is this the appropriate, like someone had asked, is this the appropriate prophylaxis? And also remind you, oh, did you restart it after the procedure? Is it constantly going? Did it fall off? But it does start with the physician and doing the appropriate risk assessment up front. So that's the entryway.
That's where our hospital medicine, that's where we really, have our forte is on the multidisciplinary rounds. We run DVT prophylaxis every day on our MDRs that are physician driven. So I'm checking that, and we have dot phrases in our notes that we always loop back to make sure that there is either SCDs or DVT prophylaxis chemically.
Great. All right, I think we're at the end of time. We're actually 1 minute over, but this is Dr. Vendegna again. Thank you for just an excellent overview on this complicated patient population, and the panelists for excellent questions, but stepping in and answering some of the questions from the audience. So this was incredibly interactive. I think very, very helpful. We're seeing a lot of thumbs up flying on that screen, so I think there's been a lot of support for this presentation today. So thank you all for joining. Thank you to the California region for stepping forward and bringing this topic forward again. So appreciate all of you, and we'll see you in our next CME program.